Thank you, and thank you to Perry Hoffman for this invitation to present today. I have a little bit of sinusitis, so if I sound a little garbled, please forgive me, and if you don't understand what I'm saying, just stop me and I will try to enunciate more clearly. So the big question, as Nikki said, is how to tell the difference between adolescence or BPD and BPD. And why is it important? I mean, I think this audience of all audiences knows the importance of it, but I think we certainly find that having a precise and a timely diagnosis may actually, in fact, lead to appropriate and relevant treatment, right? Because the alternative is no treatment in some cases. As we know, some people, healthcare providers, family members, and patients themselves might say it's just a phase, and that's a problem. And then there's others who will be diagnosed with something that is not accurate or precise at all. And we know that there are plenty of people who are given a diagnosis of bipolar disorder, ADHD, and so other Axis I disorders that may not fit, but are reimbursable and are more palatable by society in this day and age still. And by the way, in all fairness, I see some youth who are diagnosed as borderline who actually may be more appropriate as bipolar. So it doesn't just go that one direction. And I think it speaks to the issue as was brought up by a question earlier in terms of the differential diagnostic issues, which we'll talk more about. Another point I want to make is I think for this population to have some form of early intervention is a great idea. So if we can actually identify these kids in late elementary school, middle school, high school, and get treatment in early, we actually may help reduce the ongoing morbidity and mortality at later stages of life. So I'm a big fan. If I had my druthers, I'd like to create a life skills course in late elementary school or middle school. Thank you. That, and again, for anybody who has access to research dollars, because I too have had trouble with the federal government, but if anybody else has an in and wants to, whatever agency, I don't care where you get the money, but to kind of look at how we can do some prevention work. Even primary prevention would be an interesting approach to this. Anyway, so that's one point. Another point is to precise and timely diagnosis is relevant in terms of destigmatizing the disorder. In some paradoxical way, I think, certainly families and providers who will better understand the course of the illness and the prognosis with appropriate treatment. So I think if we all can get comfortable talking about it, and a question that came up earlier was how do you talk to patients about this diagnosis? A common question is how do you talk to adolescents about this diagnosis? And I say basically it's a problem with regulating your emotions and regulating your behaviors. Forget about the name. This is the core problem. And from that, you have a lot of other trickle-down effects from the emotional dysregulation problem. But if you frame it as trouble regulating emotions and trouble regulating your behaviors, it sounds much less severe in some ways. And so and if you break it down in terms of behaviors and not just a label, they actually feel much more comfortable with it, and so do the families. And so that's how we talk about it. And just to make this real life, I want to just present a couple of clients that I've seen. You know, I think many of you can relate to youth with these kinds of issues, and maybe family members in the room as well. So the first clinical example is the case of Jay. She's a 16-year-old Hispanic female who was referred to our Bronx outpatient clinic by her pediatrician after expressing suicidal ideation. 3 months earlier, she was removed from her family by Child Protective Services for educational neglect. Both her parents have psychiatric problems. The father, depressed, has substance abuse problems, and also had been violent in the home. The mother's depressed, has multiple sclerosis, and has 6 kids. And now Jay lives with her legal guardian and feels as though her guardian doesn't want her. To her credit, she's a high school senior and doing very well academically. Just a little bit of her psychiatric history. So she has a depression profile, right? Depressed and irritable mood for 4 years, vegetative signs of sleep and appetite disturbance, concentration problems, suicidal ideation, social withdrawal, rejection sensitivity. She has a PTSD profile of hypervigilance, intrusive recollections and nightmares of a past rape history, witnessing violence in the home, where father was threatening, and he had his own, like I said, his own psychiatric problems, which is not, this is not a typical presentation, obviously. And then in terms of borderline personality profile, angry outbursts, emotional lability, confusion about herself, self-injury, poor impulse control, feelings of emptiness and abandonment. And again, 5 years of depression, alcohol daily, cannabis daily at age 13, but again, to her credit, she discontinued both at age 14 after recognizing the adverse impact it was having on her school performance. Suicidal and non-suicidal self-injurious behaviors, very common among this population as well. At age 12, she took an overdose. A month later, she tried to hang herself. Age 13, she slit her arm with a razor. And at age 14, she began cutting herself more regularly, 3 times a week. So diagnosis, all right, this is where it gets challenging. So at that time, she met criteria for major depression, dysthymia, double depression as we call it, PTSD, and alcohol and cannabis dependence and remission. And she also met full criteria for BPD. So that's the case of J. Then I'm going to give you another case, the case of B. She's a 14-year-old girl, Caucasian female, referred by her community therapist and psychiatrist after she was not responding to numerous trials and medications and to CBT for her depression, her eating disorder, panic attacks, social anxiety, self-cutting, impaired interpersonal relations at school and home, alcohol and drug abuse, promiscuous sexual behavior, and periodic spending sprees. She, too, exhibited anger, mood lability, identity confusion, and other borderline symptoms. And she's also a highly intelligent girl, been in private school since kindergarten, but she hasn't been applying herself to her schoolwork. She had been previously treated for anorexia and an independent serious medical condition. Father is hardworking, successful businessman who uses marijuana daily. Mother does volunteer work and is described by the girl as her best friend. And the older brother has few limits placed on him and stays out late in the city, abusing drugs, and is mean to be. Now, so this is a more complicated diagnostic profile given her drug and alcohol abuse. So she met criteria for mood disorder NOS, eating disorder NOS, anxiety disorder NOS, alcohol, cocaine, and cannabis abuse, with a rule out of bipolar disorder and a rule out of personality change due to a medical condition and a rule out of BPD. So I bring up these cases, one, just to breathe some life into today's presentations, and I think we all can kind of, many of us clinicians in the room can relate to the multi-problem presentation that I'm sharing with you with these clients. But the differential diagnostic issues are real in terms of the bipolar disorder issues, the PTSD versus BPD, the substance-related disorders and where do they play a role in this, medical conditions as well. And so, and I think I agree with the discussion earlier in terms of the bipolar versus borderline diagnostic issue. I mean, I think you have to look to see if are there discrete mood episodes in terms of hypomania, mania, as well as depressive episodes versus many of our borderline clients, at least from my clinical experience, who often have much more rapid ups and downs that don't last for discrete weeks or days or weeks at a time in the same way. But so diagnosing personality disorders in children and adolescents is difficult due to the presence of numerous comorbid axis 1 disorders. You have to separate out BPD from axis 1, and it has to have independent presentation, developmental stage, and shorter amounts of time to exhibit the range of borderline symptoms. You might see kids at 11, 12, 13, and they don't necessarily have the history that the 30-year-olds have of multiple hospitalization, multiple suicide attempts, and other life challenges that many of the adult borderline patients present. So it makes it more difficult, not to mention the fact that many clinicians are not trained to assess personality disorders in younger children and adolescents. They don't even think about it, many of them. So I often go to sleep at night wondering, may I diagnose BPD in adolescents? This is the question. Don't you all go to bed at night? This is your question. To diagnose or not to diagnose? G. Stanley Hall, about a century ago, presented the storm and stress theory of adolescence, right? Which is, you know, teenagers are going to have some ups and downs, but they're generally going to ride it out and be okay. But more and more researchers have found that there's clearly a subgroup of youth who have more pervasive and severe symptomatology that may result in chronic personality disorders beginning in adolescence. And that's Paulina Kernberg and others. I think this audience doesn't need to review the 9 DSM-4 criteria, so I'm going to skip over those, but you know they're in your packet. So is it even permissible? Will the DSM-4, right, we keep our Bible on the night table, will it allow us to make the diagnosis in persons under the age of 18? So what does it actually say? In point of fact, it says, personality disorder categories may be applied to children or adolescents in those relatively unusual instances in which the individual's particular maladaptive personality traits appear to be pervasive, persistent, and unlikely to be limited to a particular developmental stage or an episode of an Axis I disorder. And to diagnose a personality disorder in an individual under 18, the features must have been present for at least 1 year. So the key here is pervasiveness, persistence, and lasting for more than 1 year, and seemingly unrelated to an Axis I disorder. That's easy, right? No problem. Not so easy. I mean, that is our challenge as the diagnostic criteria suggests. So that's what it says, relatively rare occasions, right? But if you look at the community studies, excuse me, and the clinical samples that have been studied, I'm so pleased to report, this is not even an exhaustive list, I just wanted to put them on one slide, so I picked out a few. But you can see from 1991 to 2008, especially in the last decade, the amount of research and publications that have been going to identifying the presence of BPD in adolescents. So there are clearly documented studies, epidemiological studies, clinical studies, that are finding the presence of this in people under the age of 18. So I don't know who we have to tell about this, but I think it's important for us to have this literature at your disposal so that when, I think there was a question earlier about what do you tell your healthcare provider in your community who says, I don't believe it exists. Well, you can refer them to some articles that actually have data rather than his impressions. So that's a place to start. Let's talk about gender differences. There's no gender differences in community samples, as I think Mary mentioned earlier. But in clinical samples, the females are diagnosed with higher rates of BPD. Bradley et al. Looked at gender as an issue, about 295 teens, and the symptoms and phenomenology of girls with BPD was similar to that of adults. And interestingly, and this may relate to what Nikki was saying, the boys meeting BPD criteria have a more aggressive, disruptive, antisocial presentation. So I think some of those kids are going into juvenile delinquent programs, and they're not necessarily getting maybe borderline-oriented treatments. They may be getting locked up. So I think that's an interesting thing to consider and look at in terms of our younger populations. But what about the validity of this diagnosis in youth? Whether the diagnosis of a personality disorder in adolescence measures what it is intended to measure. So construct validity is looked at the relationship between BPD and associated levels of dysfunction and distress, and several researchers have found that to be true. There is construct validity, looking at it in terms of other domains of impairment. So you have the diagnostic criteria and you have domains of impairment, and they correlate. Predictive validity, there's studies offer preliminary but not conclusive evidence for BPD, and I want to refer you to a review article that I recently published with some colleagues in 2008, and I'll give you that reference at the end. Reliability-wise, how reliable is this? Clinical researchers report adequate integrated reliabilities for diagnosing BPD in adolescent samples, suggesting that BPD can be reliably identified in adolescents, in Becker and Garnett and al. However, this is only a cross-sectional picture. That's in one moment in time, so of an adolescent's life. What about the temporal stability of the diagnosis? So, you know, many of us say, well, any adolescent at any moment in time could look like they have borderline personality disorder, right? Theoretically, if they have, as we heard this morning, impulsivity and aggression at any one moment in time. A teenager could slam the door, be cursing at their parent. Does that mean they have BPD? I don't think so. But so it's confounded by methodological limitations and treatment effects, which we'll talk about. Temporal stability of the diagnosis. So Garnett and colleagues found, looking at a 2-year window, that 33% of the adolescent inpatients diagnosed with BPD met diagnostic criteria at the endpoint 2 years later. So a large minority of youth still retain the diagnosis. Bernstein et al. In a large community sample found about 24% of the adolescents initially diagnosed with BPD still met criteria for the diagnosis 2 years later. And then Chanin et al. In an outpatient sample found that 74% of older adolescents retain the categorical personality disorder diagnosis after 2 years. And in that group, there's a gender difference, 83% of the females and 56% of the males. So my point of this slide is there's clearly a subgroup of youth who, at time one, if you measure them and follow them, will retain the diagnosis. Who those kids are and exactly how we can characterize that population that will hold on to those symptoms that will still meet criteria, we still have yet to determine. But I think that's an interesting area of research and to tease some of these data out. Stephanie Kaysen et al., 1999, also in terms of looking at stability of diagnosis, followed about 500 young kids, 9 to 16, and had 3 assessment points over 10 years. And they, too, found that the personality disorder diagnosis in adolescents, well, predicted young adult PD in the same cluster, independent of an Axis 1 diagnosis. And in addition, the comorbid Axis 1 and 2 in adolescents increased the odds of a young adult personality disorder. So I think, again, there's some compelling data that there's clearly some kids who are going to hold on to this diagnosis. But in terms of the stability of functional impairment, we know about the diagnostic criteria being retained, but what about the functional impairment? Is functional impairment as stable as the symptomatology? So symptom-focused outcomes may be insufficient. We have a need for more careful examination of functioning and functional impairment in diverse spheres of life, like looking at them longitudinally in terms of social, educational, occupational, and life satisfaction. So I came upon what I think is a landmark study, the first of its kind, a 20-year follow-up of well over 700 youth who had borderline features in adolescence, and then looked at them 20 years later. Fascinating study. And I was so ready to tell you about this study. I mean, I was so prepared to explain in detail about this study. This was going to be the centerpiece of my presentation. But lo and behold, Pat Cohen is presenting tomorrow on, I think, this very research, because this is her research. So I feel it would be very wrong of me to present her research today and not have her present her own research tomorrow. So I'm going to now skip over the punchline, the conclusion of this, and so I want you to blindfold yourself and skip over several slides so that you will not know what she's going to tell you tomorrow. And it's good stuff. It's very interesting stuff. So stay tuned. I'm keeping you suspense. Look, I waited 20 years to get this done. You can wait one single day. Let's be clear. All right. So moving on, I'm skipping over those slides. Now, again, we're talking about borderline adolescents diagnosed with BPD, but really at the core, they have multiple problems. And I wanted to kind of take us off on a slight detour for a moment here and talk about just how their multi-problem youth have high risk for suicidal behavior. And there was a study done by Miller and Taylor in the Journal of Suicide and Life-Threatening Behavior in 2005 that found that as you added a single problem on top of another problem, on top of another problem, on top of another problem. So if you have someone who has alcohol problems and then drug problems and then disordered eating problems and then aggressive behavior problems and so on, if you get up to 6 problems, you have a 277% increased risk of suicidal behavior. 277% increased risk of suicidal behavior. So when we're talking about multi-problem youth, I want to really mention how high the suicide risk goes up. And since that is an area of my interest in terms of adolescent suicidology, I feel it's incumbent upon me just to highlight some of what is found in non-clinical samples. This is normal, quote-unquote, normal adolescents in our American society. That annually about 17% of high school students have seriously considered suicide in the past year. 15% of whom have made a specific plan. About 9% of whom have attempted suicide. That's greater than 1 million teenagers, of whom 700,000 have received medical attention. Okay? Now, all of these folks cannot have a diagnosis of BPD. I'm sure of that. But I'm saying there are many kids in our society who have suicidal behavior, and as I'll tell you about, who have non-suicidal self-injurious behavior, who don't meet criteria for BPD, but many of the youth who we treat, obviously, who have BPD as a diagnosis also have these problems. Then we have non-suicidal self-injurious behavior. As Kim Gratz talks about, the deliberate, direct destruction or alteration of body tissue without conscious suicidal intent, but resulting in injury severe enough for tissue damage to occur. And how serious is this problem? I just want to give you an update on this while we're here. In terms of the clinical samples, about 21 to 60% of youth in clinical samples report non-suicidal self-injury. And someone asked a question earlier about what's the typical age of onset. At least from the literature that I've read, the typical age of onset of non-suicidal self-injurious behavior is between 12 and 14 years of age. That's not to say that younger children don't engage in it, but that's the typical average age of onset. So I certainly know of people at 8, 9, 10 years of age who have self-injury, but it's less common. Clinical samples, we know about 20% in adults engage in clinical samples. 80% of those are diagnosed with BPD. In terms of gender differences, again, this is a very important point I want to make among youth. It's not consistently evident. Many boys engage in self-injurious behavior. At least in the studies in the last 10 years, this is true. And I think it's surprising to many clinicians and school personnel that adolescent boys are engaging in self-injury at similar rates as girls. In terms of ethnic differences, I haven't found in the literature any consistent evidence of differences among ethnic groups. Now, this is also just in terms of non-developmentally disabled adolescents. About 4% of the adult population engages in NSSI. But among youth, among pre-adolescent community samples, about 7%. All right. And then among community samples with teens, 13 to 18%. I think there's some studies that may be a little higher than that. And then college studies, again, 12 to 35%. So this is a serious problem in and of itself, NSSI, and certainly many of the youth that we work with BPD have that behavior to deal with. What is the theory or ideology to explain this? Well, one of the leading theories, there's many theories, psychodynamic theories, interpersonal theories. One of the common explanations by adolescents as to why they engage in NSSI is it helps me to regulate my emotions. It helps to suppress negative affect. So if I'm really anxious or angry and I self-injure, it can bring my negative emotions down. It actually gets negatively reinforced, and I'm more likely to maintain that behavior because it works in the short term. And I think as clinicians, we have to validate the function. We get it. It does have a short-term effect. So I'm not condoning the behavior as a positive thing to keep on going long-term, but I do understand how it works. And I think we have to, as a clinician, acknowledge that. As well as those who are feeling numb and disconnected, it actually can upregulate them affectively and emotionally and has a positive reinforcement function for those who feel numb. So it increases feelings. So given this function, NSSI is common among clinical populations who have difficulty verbalizing emotions, which is, I think, some of our borderline spectrum youth. So when I work with adolescents who have BPD, and adults, this is true too, I think my conceptualization is they have tremendous difficulty tolerating negative emotions. They run, they avoid, they escape as much as possible. So the 15-year-old girl's boyfriend says, I want to break up with you. They feel, well, it could be a lot of things. We have to assess it, but they could feel scared, they could feel angry, they could feel sad, and they can't tolerate that emotion, many of these youth. So what they do is they engage in avoidance and escape behavior, which may result in self-injury, alcohol use, binging or purging, or what other problematic behaviors, which, as I just mentioned, provide some temporary relief. But if patients are in treatment, they'll often say, I felt some short-term relief, but you know what? I then felt ashamed that I'm still engaging in the same behavior again. I'm upset with myself. I'm angry with myself. And then that cycles a whole new other negative emotion that then creates this whole vicious circle again. So we have to help them break out of this vicious circle. So what are some of the treatment options? Well, DBT for teens with borderline personality features or the disorder. That's what I want to just talk a little bit about right now. Because I don't know how many of you are familiar with the literature these days, but in the last 6 or 7 years, there have been a good number of publications looking at DBT with youth. And Jill Rathis and I published a paper in 2002 looking at a 12-week outpatient trial for suicidal youth with borderline personality disorder features. Larry Cates did a study looking at a 2-week inpatient trial of suicidal youth in Winnipeg, Canada. Nelson Gray published a study on a 16-week outpatient skills group for youth with oppositional defiant disorder. Fleischacker et al. Replicated our work using a 16-week outpatient study with suicidal borderline features in Germany. Tina Goldstein did a study on a 1-year outpatient treatment of bipolar youth, published in the American Academy of Child and Adolescent Psychiatry last year. And Harriet Salbach came out with a paper looking at a 25-week outpatient trial with anorexic and bulimic youth. So this is kind of, actually Kristen Woodbury is not even on here, it just came out a few weeks ago with another adolescent borderline feature outpatient trial. So there's clearly some effort being made at trying to apply DBT to adolescents with borderline features as well as other problems with regulating emotions and behavior. And this is the reference if you wanted to get the suicide and life-threatening behavior article. I just want to put that in there. What we looked at was DBT with adolescents, which is weekly individual and weekly multifamily skills group, which I'll describe in a moment, compared to treatment as usual at that time. And at that time, it was supportive, psychodynamic, and family work. And what we found in this short 12-week outpatient trial, that the youth that received DBT had reduced number of hospitalizations, increases in treatment and retention, reduces in suicidal ideation, depression, anger, anxiety, and interpersonal sensitivity as measured by the SCL-90. And I also wanted to highlight, obviously, for this group that, again, compared to pre and post in only 12 weeks, self-report measure that we developed called the Life Problems Inventory, the adolescents reported that they had reductions in confusion about self, interpersonal chaos, emotional dysregulation, and impulsivity in those 4 weeks. I'm sorry, in those 12 weeks. So there was significant decline in those problem areas. And Jill Rathis is the first author on that instrument. If anybody's interested, I can tell you how to get in touch with her. And we presented some good psychometric data on that, so I wanted to actually talk to Nikki about her child measure as well and compare notes. But let me be clear, there has not been a single randomized controlled trial of DBT with adolescents, and we know there's, I think, about 8 with adults. There's yet to be one with adolescents. So we can't say this is the gold standard by any stretch of the imagination. There's just some promising pilot data thus far. So I'm consulting with Lars Mellem and others in Oslo, Norway, where they're undertaking the first, as far as I know, the first randomized controlled trial of DBT with adolescents who are suicidal and with borderline personality disorder features. And I have some colleagues in New Zealand who are also doing the same. So I just want to give you an update on the outcome data. They're looking at 13 to 18-year-olds who have had 2 non-suicidal self-injurious behavior or suicide attempts in the past 16 weeks and borderline features. Okay. As I mentioned, the central problem with BPD individuals is that they have trouble regulating emotions. And if you have trouble regulating emotions, we kind of think about this trickle-down effect where you have trouble with interpersonal relationships. I mean, again, if you're angry and upset and laid by a lot of the time, it's very hard to have steady relationships. It's very hard to be aware of what you're feeling, why you're feeling, and having a sense of self when you're in this emotional sea of discontrol. It's very hard to maintain behavioral control when your emotions are, pulling you around, as well as keeping your thinking processes grounded when you're emotionally dysregulated. And so with adolescents, we've taken these 5 kind of yellow highlighted problem areas and more simply put, talk to the teenagers about this idea of being confused about self. Do you know what you're feeling, when you're feeling it? Why did you take that overdose? Why did you cut yourself? I don't know, I just got upset. I wasn't aware, I just acted. I acted without thinking. So we get to this issue of a lack of mindfulness, if you will, a lack of awareness of what's happening in real time, a lack of how do you feel and when you're feeling it in real time. So we want to teach them mindfulness skills to address this confused sense of themselves and at multiple levels. There's the identity issue, but there's awareness of who I am and what I'm feeling right now. Then there's the impulsivity issue, right? That's the behavioral dysregulation to target the stress tolerance. There's the emotional instability issues, which we target with emotion regulation skills. interpersonal problems, we use interpersonal effectiveness skills. And then Jill Rathis and I realized, having done Marshall Linehan's original model with adolescents for a while, that there was some elements that needed to be added to working with teenagers and families. And we kind of put together this idea of this adolescent family dilemmas. We didn't put that together. We noticed that there were adolescent family dilemmas where a lot of individuals and their families were getting very polarized. They couldn't communicate. One said black, the other said white. One said up, the other said down. And kind of really polarized stance with one another. And we basically developed the walking the middle path skills to try to help them resolve some of their polarized stances, which I'll mention in a minute, and help them learn how to be more effective in terms of validating one another. Because, you know, as a clinician for many years, I used to get so frustrated before I really had any wits about me. I'd call in the family, and the parent would have a lot of legitimate things on the legal pad that they wanted to express to me as to what the problems are, and the adolescent is sitting there quaking in his or her boots because they know what's about to ensue. And I say, okay, Mrs. Smith, would you like to tell me what your concerns are? And he or she said, yes, I would. And then here we go. And that family session lasts for about 5 to 10 minutes before that adolescent's running down the hallway. And then he or she tells me later, see, I told you this wouldn't work. And after a while, it occurred to me that we needed to do something different, that this was not the best approach to family work. And so what we did was, we actually decided we have to teach validation skills to all family members involved so they can actually hear, listen, and express some overt understanding of the other person's experience, even if they don't agree with it, which would then allow us to actually do some problem solving on that legal pad. But I can't work on the legal pad until we actually can have some common understanding of what's going on here. And I hear your point of view, or I know why you feel it. I can see you feel that way, I feel differently, and et cetera. And then we can actually sit in our chairs and have a meaningful conversation. So validation skills, and Alan Frusetti and Perry Hoffman have been doing this for years with families, with adults, and so we've been kind of adapting a lot of that for the adolescent population as well. So that was one part of it. So and the other part of it was we realized that families needed help with learning behavioral principles so that the parents could be more effective at reinforcing positive behavior when it shows up. Many of the families we worked with felt burned out, and when there was some just noticeable improvement in an area, they were so tired sometimes or worn down that they didn't actually attend to it and say, nice job. I can see from a shaping standpoint that's actually better than it was before. You know, give some positive reinforcement, praise, or whatever it's going to take. And principles of negative reinforcement, principles of extinction and extinction bursts, and what's effective punishment and what's ineffective punishment. So basically we kind of do a parent training piece in this as well. But it's not just for the parents, it's for the adolescents who also need help with self-reinforcement and understanding these behavioral principles of reinforcing others as well. So this is our kind of open group where we have a 20, you know, we've done a different amounts of weeks, but this is, right now we're doing about a 20-week version of this, where you come in at 12 o'clock and we orient them to DBT. We orient them to teach them mindfulness skills, and then we teach distress tolerance skills for 4 weeks, and then we have a new entry point where people come in, we do orientation and mindfulness, and we teach walking the middle path skills, and so on and so on and so on. So this is kind of an open, multi-family group. I just actually mentioned that to you. And just actually teaching dialectics as well. I think, you know, it's not formally taught in the adult DBT program, but the notion that there may be multiple truths, multiple perspectives, that we can honor truth that may not be our own, right? So this actually helps to depolarize, if you will, the stance that's often taken, and try to help adolescents understand their parents' perspectives better, or caretakers' perspective better, and for the family members to also take a more dialectical stance, that there is no absolute truth. There may be some kernels of truth to your perspective that I need to kind of look at and honor that, as well as honoring my own. Some of the dilemmas that came up in our work with our adolescents and families clinically that we just felt were pretty common were this kind of swing between excessive leniency versus authoritarian control, where some parents might have had kind of a laissez-faire, relaxed stance, Or maybe they were just subjugating their own best intentions and wisdom because they knew that if they were to say anything, things could escalate. So they kind of kept their parental controls down, only to find that at some point things escalated, the parent crossed the parent's threshold, and they came to authoritarian control. Okay, that's it, you're grounded. No electronics for the next 12 months, right? Okay, so that doesn't go over so well when you swing the gavel down, and no electronics for the next 12 months. What the heck? So the kid says, screw this, I'm out of here, and then the parents say, okay, that didn't work, and they go back to excessive leniency again. And so helping parents and caretakers find a more authoritative middle path approach, all right, which is right out of Diana Baumann's parenting work. I mean, but again, we're talking about these dialectical dilemmas where parents swing, the teenagers themselves can swing back and forth between these poles. And let us be clear, clinicians, therapists themselves can very easily get polarized and swing back and forth within themselves as a therapist. So we want to kind of pay attention to that as clinicians too. And what about the dilemma of normalizing pathological behavior versus pathologizing normative behavior? I know somebody raised the question, you know, what is typical adolescent behavior versus adolescent BPD behavior, right? I mean, I think that was a question that came up earlier. Or how do you know what's normal impulsive behavior versus BPD? This is the million-dollar question. I think many parents look at us like, can you give us some advice on what is typical adolescent behavior? What is it? And really, I mean, my loosely working definition is, it's anything. What's typical is anything that doesn't result in impairment in functioning. Really. So if it's not impacting their social, educational, occupational, familial functioning, I would say that's in the wide range of normal adolescent behavior. So if an adolescent slams the door and has a few choice four-letter words for a parent, that might be typical adolescent behavior, I would say. But if they slam the door, go into the bathroom, and then start doing some form of self-injury, that crosses into a whole new domain. So I see this on a long continuum where at the real end is pathology, but the rest is really in the broad range of normalcy, if you will. And it's hard. And I think as for family members, I want to convey a lot of empathy that it's hard. You lose your compass. I mean, it's because, you get some ways you get desensitized, and I as a therapist get desensitized. I have kids with multiple problems that come in, and they're suicidal, they're depressed, and so on, and they're not going to school, and I'm like, that's almost an afterthought. Oh yeah, well, they're not going to school for 6 months, whatever. I mean, I actually forget that that's actually an important domain of functioning in life, but you're kind of dealing with these high-risk targets, and you lose the focus, and I think it's easy for family members to do the same. So how do you help them find the middle path so that they don't overreact, and a kid who has senioritis, do they have that in Minneapolis, senioritis? Where basically they start cutting classes near the end of senior year, or they stop, and that shouldn't send off a 5-alarm fire in the parent and say, oh my God, this kid's totally decompensating. That's kind of pathologizing normative behavior, right? So they lose their compass. So how do you help them with that? And the third dilemma, and there's multiple dilemmas. Here's just one more: is fostering dependence versus forcing autonomy. And how do we help the family members kind of find that middle path where they're not fostering dependence and doing things for their adolescent, when they really want, and as we as clinicians want, to consult to the adolescent and help them do for themselves, so they can build a sense of mastery, efficacy, and I think is partly the antidote for some of their misery and depression. Because if everyone's doing things for me, while it's nice in the short term, I feel some sense of relief that things are going to get done. I'm not doing it myself. You kind of feel helpless and hopeless and worthless after a period of time. And I think the parents, understandably, if caretakers get anxious, they want to move in, they want to help, and they sometimes help too much, if you will. Versus forcing autonomy. You know what? I've had it. You can pay your own therapy bills. You can live on your own. Go find a nice place for yourself. And that's the other pole. And so that, again, finding that middle path again too, and helping families figure out where they are on the continuum. So in DBT with adolescents, we've also, in addition to adding these dialectical dilemmas and talking about them with families, is we want to have also individual family sessions too. So they're not just in the skills group. And I don't think I made this clear. This multifamily group obviously includes I just want to point this out, this multifamily group includes caretakers because they need skills for themselves in their own lives, independent of the adolescents sometimes, but they also need skills in how to manage their adolescents' emotional dysregulation and so on. So this is, and I think you get a lot of bang for your buck getting them all coming together, having that joint experience, that Wednesday night togetherness, if you will, which also allows for empathy from other family members who are from other families who are struggling with similar issues. And so you get support and validation and skills training and shared experiences, and it's less of an identified patient issue. We are all working on this together. The family members have homework to do. They're held accountable in the same way. So I think that's an important piece. But in addition, we have these family therapy sessions where we are really trying to emphasize psychoeducation, increasing the parents' understanding of the teen's emotional vulnerability, the teen's skills deficits, and we talk about this biosocial theory with them. We try to emphasize this transactional nature, whereby the individual, we understand, has true biological vulnerabilities, and the environment sometimes doesn't know how to manage that effectively. And like I said, may overreact or underreact and not necessarily find a way to connect. And so we want to help both the adolescent be more effectively validating of the family, and the family to be more effectively validating of the adolescent. Encouraging effective communication, distress tolerance, and problem-solving skills in vivo. And again, I think Alan Frazzetti is going to talk tomorrow a lot about his family paradigm and family connections that Perry's done. So a lot of this is being done in other contexts, but this is kind of what we've been doing with the youth and their families. And then how we do this so we don't overburden the family, because you have individual sessions and multi-family skills group. It's hard to have a third session of the week to have family therapy, and people, we don't want to, as Mary said, make them kind of, so just all about being in patient care, and you want to get a life. So the way we try to do that is to divide the individual sessions in half. As I said, some of the teenagers are a little anxious about some of these family sessions, so we first meet with the kids, coach and prepare them for the family session. We like I said earlier, we talk a lot about validation and making sure they can do that before we get into problem solving. And we also do family behavioral analyses. Family behavioral analyses, again, Alan's done a lot of work on this too, is if you have an adolescent who has a problem, and we try to do a micro-analysis of this, what's the prompting event, what are the emotions, the thoughts, the feelings that led up to the problem behavior, if it's self-injury, substance use, whatever it is. Sometimes there's family members who may be a link in that chain. They may have said something, done something, and again, this is not a blame game. It just may be that somewhere along that chain there may have been a family member or something that may have had a role in this experience. The kid may have misinterpreted the family member's statement, whatever it was, but nevertheless, you can then bring a parent or caretaker in and get their chain and try to superimpose it on the adolescent's chain and see where you can learn from that and collect data that might be very useful for the adolescent. Say, oh, I didn't know you meant it that way. I see. So again, you have kind of this superimposed chains on one another that actually is very useful. So in sum, I think in terms of BPD in adolescence, I think there's a subgroup of youth who warrant the diagnosis and for whom the diagnosis is maintained. I think a lot of practitioners need to assess for personality disorders, specifically BPD, and I think why they don't is, first of all, they don't have experience or the instruments. For many child and adolescent practitioners, again, this is just anathema to them. There's nothing in child and adolescent graduate school training that's going to get you prepared to assess for personality disorders in schools and child outpatient centers. It just doesn't happen. So it's a unique breed who takes it upon themselves to go get that extra training and experience and the measurement to do that. But I would start with, just kind of keeping in the back of your mind DSM-4 criteria and trying to see if the adolescent has features of that. Another reason why practitioners don't assess for it in adolescence, as I said earlier, is I think there's the reimbursement concerns. Let's call a spade a spade. And I think there's this stigma that I don't want to, give this child or adolescent this diagnosis and then they can't shake it for the rest of their lives and the problems associated with stigma. I put this Markowitz et al. Study in 2007 which found that significant longitudinal effects of personality disorder on psychosocial functioning of adults with MDD. And why I put that in is it's just a reminder for the comorbid patients and adults. If you they found that you really need to, you have better outcomes if you treat the personality disorder first. You know, common wisdom used to say, treat the axis 1, and then we'll see what happens to axis 2. But in fact, this is the first study that I found that actually says the opposite. Treat the personality disorder, and in fact, you might see axis 1 symptomatology dissipate. Another point I want to make is that regardless of the presence of a full-fledged DSM-4, BPD diagnosis having 5 out of 9 criteria, borderline behaviors in adolescents may accurately reflect significant distress and dysfunction that needs treatment and intervention nevertheless. So I'm really advocating for a, features presentation. Kids who have 3 or 4, let's get them in and let's get them treatment. We don't have to wait for full criteria per se. And that appropriate intervention may help reduce borderline symptoms in adolescents and thus prevent long-term morbidity and mortality. In terms of our future directions, I think we need methodologically sound, longitudinal research of children and adulthood into adulthood that controls for treatment effects. And so, please, all of you guys who get the funding, please do that. Thank you. And then randomized controlled trials needed with adolescents with borderline personality features. I think I'd love to see various theoretical perspectives on this. I know there's this RCT, like I said, in Oslo that's underway. There's one in New Zealand about to start. So I agree. I think I've been trained in DBT, but I think whatever is working and effective, I'm happy to learn other treatments. Whatever's going to work for these youth, we need to kind of get it in there and get it in early. All right. Thank you very much. For those of us with BP parents, how do you determine whether a child's behavior is learned behavior from a borderline parent or is indicative of a possible BPD diagnosis? I'm not really, I guess I'm not so concerned about where it comes from. I guess if an adolescent is exhibiting behaviors that are problematic in their life, I want to treat it. If they're living with a parent who has BPD and there's some kind of transaction which maintains it or reinforces it, well, certainly I want to do some family work to make sure there's not a reinforcement for that pathological behavior. But nevertheless, I want to teach this kid some skills so they can manage their emotions and impulses more effectively. And so that's the primary goal. If it is, like I said, if it's maintained somehow in the family, we've got to do some family work as well. Any speculation about DSM-5 and BPD in adolescents? I'm afraid I'm not in that inner circle to have that information. I wish I did. So I don't know, and I don't want to speculate. I have a feeling it's going to be, as we were hearing before from Nikki, I have a feeling they're not going to necessarily change the age cutoff, but I don't know. Related to adopted adolescents with BPD, self-identity issues, can DBT be effective if they have not yet come to terms with who they are in their adoptive family and who they are in their biological family? Well, I think it's a good question. I think in DBT, the first part of the treatment is kind of getting severely out of control behavior under control. But once you do that, and hopefully you can do that in a reasonable amount of time, you then want to move into helping them process these issues about loss, about separation, about identity. But you can't do that when they're actively out of control. So it kind of has a stage model where stage 1 is kind of getting severe behavior under control, and stage 2 is processing these things and helping them with their longer-term goals in the process. Concerning non-suicidal self-injury, does adrenaline rush created by self-injury calm the neuroemotional system? Might that create the cyclical SI calm loop? Yeah. There's definitely some biological component. For some, it becomes almost an addictive behavior that has a biological orientation to it. So yes, I think it does have that. Nevertheless, I still think behavioral interventions can be useful to break that cycle, but it's just that much harder. It's just that much harder, but for sure. Why the drop in incidence of BPD in various studies of adolescents as they age? Is it burnout? Is it treatment? Is it unknown, or all the above? The drop in incidence of BPD in various studies of adolescents as they age. I'm trying to remember. I actually don't know if that's true. I'm not sure that. I think that may be. Whoever wrote that question, do you want to clarify that, or rather not? Yeah.
In the first several studies, you showed a number of years later the percentage had dropped.
Oh, I see what you're saying. In terms of, right, I'm sorry. In terms of the stability of the diagnosis, right, yes, thank you. Is it burnout? Is it treatment? Is it unknown? Yeah, that's the million-dollar question. In other words, there are some subgroup of kids who maintain and retain the diagnosis, and why is that? And are there certain features, factors in their presentation that have maybe more of a biological basis, maybe more environmental basis? It's hard to know exactly what sustains them. Whereas others, like you may have been just in the midst of a family crisis or some bullying situation, and they exploded and met criteria at that moment, but actually after that environmental situation resolved, maybe they didn't actually have, in point of fact, really have a long-standing, ingrained personality issue there. So I think it needs to be evaluated in more depth. Yeah, we don't know. I have several labels or obstacles very similar to case studies of J and B. Where should one begin? Which is the priority for treatment? I.e., my fear is once I stop one negative coping skill, for example, overspending, it increases my desire and almost need to self-harm. What to do? I'm losing hope and energy. Okay. I mean, that requires, I think, a little bit more discussion, and I guess whoever that is, I'm happy to talk to you at one of the breaks or at lunch, and we can discuss that in a little more depth. Is it common for children or teens to do extremely well in school academically but struggle when entering college and the workforce? So I assume that means children and teens who have BPD who are doing extremely well in school academically. But yeah, I think transitions in general for many of my clients are difficult, and so from middle school to high school is difficult, from high school to college is difficult, from college to the workforce is difficult. So I think those, if we conceptualize them as having a biological emotional vulnerability, that they're highly sensitive and reactive, and then you add a stressor, a stimulus that they have to then contend with that's unfamiliar to them, I think we can predict that there's a higher rate and risk of them being more dysregulated. And so we want to cope ahead with whatever that transition is as far in advance as possible, to anticipate, to role play, to anticipate what are all the potential obstacles that you're going to deal with when you go to the new school where these kids you don't know where your classes are, et cetera, et cetera. So I think there's a lot of work that we do in coping ahead. Is it hard to find support for self-injurious behavior because those that engage in it tend to compare and compete regarding their scars? What do you recommend for adults and teens and kids? Well, it's a good question. I mean, I think there are a lot of websites that don't promote healthy behavior out there, and many of you have probably seen those. But there are websites that actually are, I think, I don't know the names of them off the top of my head, but my clients have told me that they that they've come across some websites that offer some support that are not pro-cutting behavior, that they're actually, and they, I had one patient in New York who was saying they spoke to some patient in San Francisco who was in a DBT program there, and they were comparing their treatments and less so their self-injurious behaviors, and it was much more of a supportive conversation. So there are some programs and websites that might be useful for that. But I think adolescents are more prone to social contagion, certainly, than adults with suicidal behavior, and I think certainly with self-injurious behavior. So I think I discourage them from talking too much to their peers about it, and I encourage them to talk to their, to their therapists or school counselors or someone who's able to listen to it and manage that more effectively. So I don't want to foster too much discussion in groups of youth regarding that. How long in each session? How long is each session of the adolescent family group? There are varying lengths. My program has a 2-hour multifamily group, but I know some folks, that run an hour and a half. Some have 2.5, but I think on average it's about 2 hours. Please lay out of time in teaching versus check-in. Please lay out of time in teaching versus check-in. Other structure. So the groups are basically 2 hours. The first hour is typically reviewing homework from the last week. And you really, if you're going to teach these skills, you got to check in on homework, because if you don't, they don't think you actually care. And if you don't, you can't actually catch what they're not getting. And to me, that's where the learning is, going over homework and giving feedback, homework feedback. So you want to leave at least 3 to 5 minutes per member for homework review. And if they didn't do their homework, you want to leave 3 to 5 minutes to figure out what got in the way of them doing their homework. So either way, everybody gets 3 to 5 minutes, and that's about 45 minutes to an hour, take a little break, and then teach new skills content. That's how we do it. And then in terms of clinical samples, problems of NSSI, 21 to 61%. Is this the average population? No, so that's the clinical population of adolescents. And the percentage of youth involved in treatment of some sort, I don't know. Excuse me. I don't know what percentage of the youth in those studies have been involved in treatment. So I don't know the answer to that, actually. Are we right on time, Perry? Is it lunchtime? All right, thank you.